Hello, and welcome to the first of a three-part video series that seeks to teach you the basics of using an ultrasound imager to assess knee osteoarthritis. In this video, we're going to focus on the osteoarthritis side of things by taking a quick look at some current literature, and we're going to try to answer the questions of what is knee osteoarthritis, who's at risk for it, how is it identified, and how can ultrasound be of help? Uh, I'd like to acknowledge first that this project is generously supported by a grant from BD Health, and it was administered through the ICUNJ. I'd like to thank both of them very much for their support. Now let's get into it. So first and foremost, what is osteoarthritis? Most people are familiar with this as essentially grinding of bone against bone at a synovial joint, where there should be articular cartilage covering the ends, the cartilage has worn away, and now you just have bone against bone. At least this is sort of the way that it's often thought about. You often hear people saying things like, oh, you shouldn't run too much because you're going to wear away the cartilage. A lot of more recent research suggests it's a lot more complicated than that. To quote this article from the Journal of Clinical Medicine in 2022, osteoarthritis is a complex multifactorial joint pathology caused by inflammation and metabolic factors underlying joint damage. And the actual, if I can pull up my spotlight here, the actual progression of knee-OA goes a little something like this. Normal, I don't have an image of normal cartilage, but normal cartilage, you should have, bone, a layer of cartilage, and that layer should be very smooth. Early on, what they see happen is the smooth layer begins to get a little crinkled. The cartilage itself might start to swell with extra fluid, and what they call the bone plate, the layer of cortical bone just beneath the cartilage, will become more porous. As it progresses, that bone plate will thicken, cartilage will swell more, and the collagen fiber matrix within the cartilage itself is going to start to degrade. As it progresses, you will see, deeper fissures within the surface of the cartilage, the beginning of osteophytes, which is sort of growths of bone into the cartilage, up through the bone plate. And then eventually what you start to see is the chondrocytes, the cells that live within the collagen matrix of the cartilage, will begin to die off. Starting from the bone plate up, that cartilage will begin to calcify. Blood vessels will sort of invade that newly calcifying areas of bone. And ultimately, what you're left with is a cartilage that can no longer take care of itself. And you are just in basically a degrading from here on out. It only gets worse. It does not get better. This makes it really important to be able to identify osteoarthritis early. So who's at risk for this? So this comes from an article published in the Journal of Orthopedic Surgery and Research in 2023. It's a systematic review. They looked at 29 cohort and case control studies to try to identify what are the most common risk factors associated with developing knee osteoarthritis. About 32.5 million adults are estimated to be affected by this condition in the United States. And current treatments mainly focus on symptom relief. As stated in the last slide, once you've reached that end stage, you can only degrade. So identifying it earlier lets you take steps to slow down that degrading process. And what this does is it basically stretches out the life of your knee. The current treatments focus on symptom relief. The main symptoms are pain and stiffness. Early on, that could be some anti-inflammatory drugs or pain relief drugs, a little bit of exercise to keep the joint moving. But eventually, when the pain gets so bad that there isn't anything to be done about it, pharmacologically, you end up with a joint replacement surgery. But, that's a major surgery with some risk factors. Also, the joints replacements don't last forever themselves, and you don't want to get to a situation where you have to have a second major surgery to replace the joint replacement. And so identifying NEOA early lets you slow that degradation down and make sure you are you can basically live out your life with either one or no knee replacements. So based on these 29 cohort and case control studies, the most significant risk factor by far was trauma history. If you'd had a serious knee trauma at some point in your life, you were much more likely to end up with knee osteoarthritis. So that can include things like ACL tears, meniscus tears, medial collateral ligament tears, things along those lines. A BMI over 24 kilograms per meter square was also identified as an important risk factor. Two things jump out about this. Well, one, you'll notice that 24 isn't even qualified as overweight. That's actually the high end of a normal BMI range. The other thing that jumps out to me about this is in exercise science in particular, we often kind of poo-poo BMI because it doesn't directly address body fat, which is mostly what people are interested in when they're looking at BMI. But in this particular case, we're not really interested in body fat. We're interested in load on a joint. So it doesn't really matter if you achieve this BMI because you are over fat or because you are, have a lot of muscle hypertrophy, or, heck, it's only 24. You don't even really have to have that much of either of those. Just, the heavier you are, essentially, the greater the risk factor is. And it was up there with trauma history as one of the most important risk factors. The other two most significant risk factors, female gender and age. More about age in particular in a moment. There were also a couple of protective factors that were identified, particularly exercise and educational background. People who move their joints more frequently, it tends to lead to healthier joints, as long as you're absent any sort of major trauma. And it's hard to really pinpoint exactly what it is about educational background. It likely has a lot to do with socioeconomic status and resources and those sort of things. So that's who's at risk. How do we actually go about identifying it, and how reliable are these indicators? So this study was a 10-year sort of assessment using the American College of Rheumatology criteria for hip and NEOA in early symptoms. So what the study did was they had, I believe, about 900 participants with NEOA. Some of them had NEOA and also hip OA, but they were identified when they first came into a clinic as meeting this criteria. Went through some follow-up imaging to confirm that it was in fact NEOA. And then every year, once a year for the next 10 years, they came in and they were reassessed on this criteria. So the criteria is you have to have pain in a knee, plus at least 3 of these 6 possibilities: an age greater than 50, stiffness, particularly stiffness when you first wake up in the morning, crepitus, which is kind of a grinding feeling when you move your joint. Most of you, if I'm assuming most of you watching this video are probably fairly young, so you probably take it for granted that when you move your joints, it feels very smooth. You don't really feel anything at all. But that's not true for everybody. Crepitus is that grinding, creaking feeling you can get when you move a joint. Bony tenderness, by this we mean if you palpate, if you touch a place on the bone, or in this case along the joint line of a knee bone, it's painful. Bony enlargement, feeling sort of abnormally large spaces when you palpate, and an absence of any kind of palpable warmth that might indicate some other inflammatory process is going on. So when everyone came in for that first visit, they met this criteria: pain plus at least 3 of these things. What this study found is, as they followed up with people year after year, even though they had a confirmed OA, They did not always present with the same symptoms. In fact, only 8% of the roughly 900 participants actually consistently met this criteria year after year after year. But the ones that were most consistent are the ones I highlighted in bone: pain, crepitus, and bony tenderness when you palpate them. They are the most consistent diagnostic criteria that they find. This study, it also pegged the mean age of onset, at least amongst the participants in this study, was about 56 years old, which is pretty normal for NEOA, though it's not unheard of for it to start younger. It's fairly common for people in their 40s to start having a lot of these symptoms. It's not unheard of for younger than that to have them, but like I said, as a mean, 56 is about where most people start feeling these things. All right. So we have those symptoms. They're fairly easy to assess, but we know that they're not always reliable. From year to year to year, people will report different things. So you can go to imaging, and some people use X-rays, some people use MRIs. Part of our question here in this project is, can we use ultrasound? Ultrasound has a lot of advantages. There's no radiation. It's a lot faster. It's a lot simpler. It's a lot cheaper. But is it good enough to really sort of help us understand what's going on in a knee? Well, this study from Scientific World Journal in 2021 took a close look at ultrasonographic assessment and compared it specifically with a 3D MRI technology. So first, important to acknowledge, there's a few limitations about the ultrasound that we'll get into more detailed in the next video. But the main one is that we can only access superficial knee structures. So you can get a pretty good look at most of the femoral cartilage in most people. Sometimes the lateral condyle is kind of hard to see, but most of the femoral cartilage you can see pretty well. It's hard to see very much of the tibia, though. So you're not going to get a good look at most tibial structures, but we can get a good look at the femur. When you do get a good look at the femur, typical cartilage thickness in the femoral sulcus, where the sort of patella tracks in that groove, was about 3.17 millimeters. And then from there, it tapers down to about 2.04 millimeters on the medial side, 2.08 millimeters on the lateral side. These are, remember, these are both averages. So if you have a larger person, it'll probably be a little thicker. If you have a smaller person, a little thinner. When you get onto the actual condyles themselves, a little thinner still, particularly on the medial side. 1.95 millimeters was a typical cartilage thickness, and 2.17 on the lateral condyle. These, but probably the best part from our standpoint is these measurements really highly correlate with what is found on an MRI. So even though this is a much faster, much less expensive, much less time-consuming way to assess things, they do give us pretty reliable results. They tend to be consistently thinner measurements than MRI. So you can't necessarily take the ultrasound cartilage thickness and compare it completely with the MRI thicknesses, but they are consistent. And that makes them useful from an assessment standpoint. So the key takeaways so far, remember that NEOA is a progressive disease that involves changes in both the cartilage and the bone underneath the cartilage, that subchondral bone. The ultrasound is only able to see superficial features of the joint. In particular, the cartilage along the femur is the most easy to assess. So it's not the perfect tool, but it is fast and reliable for what you are able to see. But also keep in mind, ultrasound findings are going to need to be considered in light of the other risk factors: the person's age, gender, injury history, also the symptoms that the person is experiencing, pain, crepitus, and bony tenderness in particular. So that concludes part 1 of this series. The next video is going to take a closer look at ultrasound, particularly what we call musculoskeletal ultrasound. What are we seeing and how does it work?